it restricted inversion and inversion, and they started physiotherapy earlier. So this study had good follow-up up to 14 years, and it found there was no difference in the ankle scores. All patients got back to playing sport, had ankle stability, had normal range of motion in both groups, and importantly, 3 of the patients in the operative group had complications of paresthesia after the operation. For what it's worth, they did an X-ray and an MRI at the 14-year follow-up, and for something they can't explain, 4 patients in the operative group had grade 2 osteoarthritis on MRI compared to none in the functional group. This study was done 20 years ago. They looked at 12 prospective randomized controlled trials. All of them compared between a surgical group and a cast group, which is something that's prehistoric. The other 7 groups also had a third arm, which was those treated functionally. And all patients did well, irrespective of what kind of treatment they actually had. So in terms of return to work or physical activity, 6 studies reported on this. 4 of the studies had 3 arms, which included a functional arm. And in those studies, they returned to work and sport 2 to 4 weeks quicker. Or 2 to 4 times faster than the group that was treated surgically or in a cast. Even the groups that were treated just in a cast were at least quicker than those treated with an operation. In terms of mobility for ankles, of the ankle, the groups that were treated functionally had a better range of motion earlier. So dorsiflexion was the main problem in the group that was treated surgically. And Evans in 84 noted that mobility at 3 months was significantly impaired in the operative group, however did normalise at 1 year. In terms of returning to their pre-injury level of activity, non-operative treatment was superior in 4 of the studies. And Moeller-Larsen looked at 3 months at the fact that only 56% of the operative group had got back to the level of activity, compared to almost more than 80% in the functional group. Van den Hoogendan in 82, who also swam in the Olympics thereafter, he had a very large discrepancy. At 9 weeks, the operative group, only 7% had returned to their level of activity compared to 68%. And this gap had actually increased by 3 months. And there was still a difference at the 6-month mark of 10%. Objective mechanical stability. So for what it's worth, we know that objective stability and subjective stability often don't correlate. But Summer in 99 showed that functional treatment is better than surgical treatment in terms of the Taylor tilt. So you measured Taylor tilt at injury and at 1 year, and found that there was a 14-degree improvement in the group that was treated functionally compared to only 9 that were in the surgical treatment group. Complications. There are lots and lots of complications from operating on these patients. Some studies had a 4% infection rate, had 7% dysesthesia. Glenn mentioned Brostrom's trial or his article in 1966. He had a complication of skin necrosis and needed a skin graft for one of his patients. We wouldn't tolerate that. In this group, 4 of the patients that had a cast for 6 weeks had a DVT. None of the patients in the functional group had a complication. Simple answer, we should treat these patients functionally. So the conclusion was that in all the 7 studies that had 3 arms, functional treatment is the only choice. This was a good trial. This was a good study looking at 2 arms again of young active male patients that had grade 3 injuries, and it's often argued that potentially there is an area that you would treat patients who are young, athletic, with grade 3 injuries with surgical management. So this study looked at that treatment group and had a 2-year follow-up, and their main finding was that the return to work was far quicker for that in the functional group than in the surgical group, and they looked, like I mentioned, in that group that they called complete instability. So they had tibial talar tilt of more than 20 degrees, and found that there was no difference in treating these patients operatively. The Cochrane review, as Glenn mentioned, there's lots of findings in Cochrane review, and it's got 22 trials with 2,500 patients, so you can find whatever little snippet of information you think is relevant for your talk. But there definitely is evidence that they take longer to recover, they're more stiff, and they have lots and lots of complications. And their conclusion was that they don't advocate the use of surgery in these injuries. This article, which I thought Glenn was going to bring up, is the only thing that I could find in recent literature which says that it's better to use in operation than to treat these patients functionally. There are lots and lots of weaknesses. I have to put 2 slides to fill in the weaknesses column of this article. They looked at 27 trials. The far majority were in the 1960s. So this is all Brostrom trials. They compared surgery with cast mobilization. They didn't have a lot of studies that compared functional treatment with surgical treatment. They had very short-term follow-up, and some had very small patient cohorts in their study. And they only looked at 3 outcomes after looking at 27 trials, which is time lost from work, pain, and giving way. They derived their conclusion because there was a difference in giving way between their 2 patient categories. There was no difference in pain or time lost from work. So as I was mentioning, there is a difference in functional instability, and which is objective or subjective instability. And Kovac, who I showed you the article a minute ago, had 123 patients that had objective stability on stress X-rays, but 9 patients reported instability. And conversely, 23 patients that had objective instability, but only 8 of these patients thought their joints was unstable. So 15 of them thought or had no symptoms of instability at all. The cost of surgical treatment, there are 23,000 sprains per day in the USA. This is an enormous financial burden on operating all these patients, and we would overtreat thousands of patients who would go very well without an operation. It saves the patients from additional trauma to the tissues, and it avoids bad complications. If non-operative treatment fails, the results are fantastic for late repair, and tiling showed that even 13 years after injury that you get fantastic outcomes, and they are comparable with primary repair techniques. So in conclusion, functional non-operative treatment is the only choice for this injury. Excellent outcomes, you get the same scores, you get a quicker range of motion and return to work and normal activity. You get a stable ankle that's functional, it's cheap to treat, and you don't get the complications that operative patients get. My technique of non-operative functional treatment, again, your aims are recovery of range of motion, strength and coordination. So again, it's rest, ice, compression, elevation. Initial immobilization while the acute setting for the first 48 hours. Weight bearing to tolerance, which is important. And you can use ankle supports, which prevent eversion and inversion, but allow plantar flexion and dorsiflexion. Physiotherapy started immediately with range of motion strengthening and proprioceptive training. And you want a 6 to 12 week rehab program that also looks at strengthening your perineal musculature. To think that opposing a tiny ligament that looks like a little piece of bacon, and that's going to give you that's going to give your ankle stability, just doesn't make sense. I think that the proprioceptive fibers will heal with functional treatment, and the important factor is to retrain your proprioceptive fibers and make sure your perineal musculature is intact to give you a stable ankle. You can use ankle supports throughout the rehab period. And in terms of physio, I think there's 3 real phases. There's the initial phase where you're getting over the acute injury. There's passive range of motion exercises. There's Achilles stretching to improve dorsiflexion. It then goes to phase 2, which is contrast treatments. You get strength training with isometric and dynamic exercises before you move to stage 3. Once you're pain-free, you've got a good range of motion, and then you're back into the sport and normal activities quickly.